So I'll just let other folks, and as we start, my computer tends to do that. It tends to jump to another slide without me touching it. It's not haunted. I have no idea what's going on. Um, so the goal for this lecture is really to go over how we think about race and ethnicity and other demographic factors we are going to cover for in other lectures, and understanding how social determinants present for different demographic groups. And it's not going to be just, regurgitation of the reading, but more so to bring your attention to various literature and a summary of some results across the readings and other literature I've added to give you an idea of when you hear demographic factors as demographic characteristic as risk factors for various conditions. I really hope that you ask more questions. So, and that's the goal for this lecture. Please ask any questions. Stop me in the midst of anything. I'm not very formal. There's no such thing as a ridiculous question. So please ask questions, comments. I may ask you some questions because I want this to be interactive. I do not like, to hear my voice all the time. So I want to hear what you have to say. You have a reaction to the lecture, to the readings and other materials in the course, and that really matters. So I want to hear your sentiments, your disagreement, and your critique of what you've read. All right. Let's start. So a lot of public health literature, and as I mentioned in the beginning of the course in the introduction video, that if you are an MHA student, social determinants is important to you because you are interacting with people and you're providing service at whatever level. You must really be mindful of potential factors, experiences, mechanisms that may really impact engagement in care, continuous engagement in care and clinical outcome. So if you've looked at the literature, even if before you took this course, you may have seen that race and ethnicity are social determinants of health. They're meaning that when you look at health disparity and health outcome, you tend to see a race difference or ethnicity difference. For example, there are a lot of established disparities in various clinical outcomes, in terms of cardiovascular related conditions among African Americans and non-African Americans, for example, whites, or among Latinos and African Americans and among Latinos or whites. So race has been also associated with increased risk for certain conditions, psychiatric conditions like depression, and prevalence of anxiety. Again, I have to tell you, I have no idea why it might be something new with Zoom, but I have no idea why it's going to the next slide. But anyway, at times I will just bring it back to keep self focused. I have looked at the setting. There's nothing I can actually do about this. But anyway, so the reason because if you've taken public health related courses, at times they don't talk about psychiatric conditions, medical conditions tend to be a focus. However, psychiatric conditions like depression, anxiety are very much prevalent in our society and really globally. There's not the high prevalence rates mean nationally and internationally means that when you're interacting with a patient, the likelihood that a patient that you're seeing has a comorbid medical and psychiatric condition is very high. So when we talk about social determinants and health outcome, we're also talking about mental health outcome because the disparities, there's some determinants that are associated with poor outcome for certain groups. So in several studies, in addition to race, look at that religion being Muslim is associated with various poor health outcomes as well. So this happened in 2017 when this, well, recently in 20, I think probably a few months, although it felt like years if you do this type of research when you heard about NIH canceling a lot of grants. So our current administration does not believe in health disparities. As a result, it has canceled a lot of grants that research that focus on racial disparities, minority, and we'll talk about GLBTQ plus population as well in subsequent lectures. And so these, and the reasoning for this is that they do not align with the priorities of this government. The goal of this lecture is not to take a political stance, but more so to talk about science. I do not, your political beliefs really is not really, it doesn't really matter to me, but more so let's talk about science. Let's talk about things that affect all of us. Including other minority groups who are already at a very disadvantage in terms of science. So some of the cancellation have been challenged in court, including Stony Brook. I think Stony Brook probably among the university in New York that actually challenged some of the cancellations, but all of us who've done some health disparities and were funded by the government by NIH, which is the National Institute of Health. We were holding on to our everything to see, okay, because canceling a research of science is that we are essentially taking numerous steps back in terms of what we have accomplished. But this is important because if we're talking about health disparities and health outcome, when we have research targeting that has been canceled, then not only knowledge, but also practice. So I want you to think about, because whenever we talk about social determinants of health, when I've taught this class before, some students may ask, well, I'm an MHA person. Why is this relevant? And I said, that's a good question. Let's talk about it. Because these are not just research. These really help really inform clinical practice. Right. So many years ago, and I'm new to New York and new to Stony Brook overall, but a lot of my colleagues were saying who actually seek medical care at Stony Brook would say, well, they wouldn't ask you about like food insecurity before. If you were a woman who had given birth, they wouldn't really ask you about potential postpartum depression before. So all of these things were implemented, not just at Stony Brook, but in other hospitals because of the research, right? These are things that, they're not implemented just because somebody thought about them, but it's because the research show, well, you need to, assess for food insecurity, housing insecurity, because these things impact how your patient population engage in treatment. So I wanted you to think about, like, when you see research, it's not just, some researchers just sitting somewhere in their high chair, but more so it is really relevant to all of us. And it really can inform how we interact on a day-to-day basis. Not that I'm saying that every person you see who is part of a demographic subgroup or population, you must like assume, but more so overall, the population you're working with, it's important to think about what are some social determinants that might be relevant to these individuals, and I should be mindful of in terms of, options for treatment and conversations around food insecurity. Any questions so far? Okay. So disparities, why does it matter, right? Disparities in health is not a figment of our imagination, even though some folks do believe in that. And disparities in health is not only race and ethnicity. And you will see in the scores and other lectures where we'll look at rural population as well. where we'll look at, not only sexual minorities, but sexual minorities and then demographic factors, the interaction of being a sexual minority individual and living somewhere in a rural area. So health disparity is basically what are some demographic factors, as defined like, by NIH or other, like the CDC, that makes you more prevalent to have a certain outcome in comparison to other groups. So disparities in health and mental health conditions, your lecture, rather your readings have covered it. So cover all of these differential outcomes across in comparison to race, ethnicity, and some other demographic identities. Some of these conditions include diabetes, asthma, cancers, cardiovascular diseases, hypertension, okay, anxiety to psychological distress. Disparities tied to diabetes, for example, much more prevalent among African Americans and Hispanic. Cardiovascular diseases, African Americans, tend to die from these conditions more at a higher level, at a higher rate rather than their white counterparts. And being a certain, affiliation, religious affiliation is also being seen as to have increased risk for depression and anxiety. Some of this research also that looks at Muslim identity in particular also was conducted around 2022. There are various racial and religious unrest groups are being targeted. I mean, they continue to be targeted, likely at a higher rate, or it may be not covered as much. So we do see there's some contextual factors that explain the disparities, not just, being Muslim, but being Muslim and the social phenomenon that is going on. So in addition to various other medical conditions, we also have differences in health behaviors, physical activity levels among race and ethnicity. Very, very significantly with African Americans or Latino, less likely to meet recommended guidelines for being active. And the recommended guidelines, if you're interested in ever in jeopardy and that question is asked, is 150 minutes of moderate to vigorous as part of the definition weekly activities. So why have I included behavioral health in terms of looking at disparities among race and ethnicity? What are some things, why physical activity? What do you think? Jen?
Well, certain people may have gym memberships or have access to gym memberships and go and do workouts and that kind of thing. It may not be popular amongst certain ethnic groups and
Mhm.
things like that, or they may not have the ability to join a gym, for
Mhm.
example.
Yes. Yes, great answer. Alexander, yes.
So I also think because I was actually going to talk about this in our response that's due on Thursday. And I think it also has to deal with too is the social circumstances of what the family life is like, where if you're a single mother and you're working two jobs, you may not have the opportunity to go to the gym or take care of yourself.
Mm-hmm. Mm-hmm. Yes. These are different yet absolutely noted barriers in the literature in terms of seeing different physical activity levels among racial or ethnic groups or around or among single mothers versus two-parent households. So anyone else? Okay. Yes. The access, right? So Jen mentioned some factors related to access, right? Not being able to afford a gym membership, which apparently around New York and Long Island, this will cost you an arm and a leg. Uh, so, so it's not that people may not be interested in being active, is that this is a barrier because affordability is low, right? So, and that really is important. Why would this important if you're an MHA person and you're part of a clinical group and you're working with patients who are overweight or obese, and as part of the health program? Why might that be important? Gym membership important? Why you ask about that among your patients? And Jen mentioned,
To,
yeah, go ahead. Yeah, go
to,
ahead. And Jen, then Alexander.
Well, it just I'm a physical therapist, so I
Hmm.
work in the hospital, but I know like for outpatient, and if you need to go to physical therapy, there's often a copay, and some people can't afford the copay to continue their visits.
Hmm.
And as Alexander said before, also the time, can you go 3 times a week to PT? Do you have the time in your schedule if you're working 2 jobs, taking care of kids, whatever the case may be? It may be
Hmm.
very difficult just to have that ability or the time. Um, that was what I was thinking of immediately is the
Oh,
PT aspect.
absolutely. I love how you guys are bringing your work area, your areas expertise and making it very practical. Absolutely. Yes. Alexander?
she kind of answered it.
Okay.
It
Okay.
was something similar. Yeah.
Well, great minds think alike. So absolutely. In this research, of course, years of research, part of it was born out of just, for example, primary care doctors will get really uh, not overwhelmed, but to the point that, well, patients are not engaging in care, despite the fact they're coming to see us. We provide a plan. For example, I was part of an obesity program at Brown University when I was a postdoc. And part of it was just, I mean, it's very, I mean, you meet with a nutrition, a physical therapist, you meet with a cardiovascular. I mean, everything was tracked. It was a very comprehensive program. However, it's just the simplest thing that forgot to ask. You know, the copay might be $10, but can you afford it for the duration of the program? So it may be that you have a very great comprehensive program, but it's not finitely tailored to your population of interest. So by knowing the literature and saying, well, and again, nobody is a pure repository of anything. So it doesn't mean if you're Latino, you're gonna be this, you're gonna be that. If you're no, but more so, we know and we'll talk about various systems to why we're starting with demographic differences and across conditions and health behaviors, and then we're gonna go into the various systems that really explain these things. But making sure that folks are, if you're providing a program, you think about availability of folks, their work schedule. What is the work schedule of your patient population? So if your clinic only offers 8 to 5 and people are getting off work at 5 o'clock, uh, the lack of engagement in the program may not be due to a lack of motivation. It's just reality of their lives. They have to prioritize their work instead of PT. It's not that they don't want to get better, but however, at times it's misinterpreted as these folks are not very engaging in their care, pathologizing folks as you're not interested in health. And there are some folks, regardless of resources that you give them, they're just not ready to change. But however, on average, folks have things, competing demands for their time that most often explain the lack of engagement in care you may see. So these are some other ways in seeing even among children, we're seeing that type 2 and type 1 diabetes tend to have higher prevalence rates among children in comparison to adults. Among white children in comparison to Black and Latinx children, there is a greater access of insulin pump. Greater type 2 diabetes. And lower access insulin pump among Black and Latinx children. And that's really problematic because not having your insulin pump or not having your medication increase the likelihood of, premature mortality. So again, these things are not in fact, or not things of the past. These things are things that are happening right now and continue to happen. HA1C levels, which is your blood glucose, rather, glycemic control, whether you have poor or high glycemic control. So if I have type 2 diabetes, I have poor glycemic control. So as a result, you do have to take medication to make sure that you manage your blood glucose. So we see, compared to white and Black children, there are various disparities. So the likelihood that you are going to manage your type 1 diabetes if you are a child who is African American or Latin or Latino child in comparison to whites it's the disparities is really large, and it's widening, especially now because a lot of community level support have been canceled because again, some of these things do not align with the priorities of this government. So the goal, I really hope in this class, and again, I think in any public health classes that we do, is that when we talk about race, when we talk about gender, sexual minorities, whatever descriptors or demographic characteristic we're talking about, it's really important to think of it. Yes, it is associated determinants of health, but there's nothing intrinsic about being Latino, being a woman, or being African American that tend to explain these disparities that, there's nothing really genetically to say, well, you're likely to be poor based on these genes. So we're talking about context, right? And this is really important because oftentimes, I remember when I was in grad school and I was taking a class on public health on disparity, and I was like, oh my gosh, it feels like people like me are just not doing anything. We are doomed. We are doomed. As an African American person, I am doomed. I did not know that. So until I started working in labs of different researchers are showing me, well, there's a lot of layers underlying what we are seeing. It is not just folks, and we'll talk about, as I mentioned, rural areas where Appalachia, which actually is a really contentious discussion, especially with this government, with our vice president basically saying these folks, they need to pull themselves by their bootstraps. Okay. And again, we're talking in the context of science, not political stance. So thinking about what are some factors that really interact to explain these inequalities is really important. So as I mentioned earlier, we were seeing, during the time of various unrest, including religious unrest, starting in 2017, when there's the Muslim ban, and well, it was not a Muslim ban in quotation. It was actually, yeah, our president did say it was a Muslim ban, verbatim. So we see an increase in anxiety and depression among people who, were of that faith. Because if you are, of course, afraid for your own safety, the likelihood you're not going to be anxious is very low. But why does this matter? So I believe in this course, we talk about the physiological impact of anxiety and depression. But briefly, I'll mention if you are anxious, and this might be an overview for people who are aware of the physiological impact of depression and anxiety. So if you are anxious, right, our body is wired to fight or flight. So if we are anxious, there's a physiological reaction. And I'm not talking just normal of anxiety. You have a paper due and you're kind of worried about getting it in. But I'm talking about in high level anxiety continuously, where it's hindering your level of functioning. So when your anxiety increases, your body does not know whether or not you're reacting fearfully because there is a lion in your environment, or it just coming from your mind. So as a result, the body will react in order to protect itself, right? So as a result, when the fight or flight system, is enacted, for example, your digestive system stops because you don't need your digestive system if your body is prepared to fight, right? So as a result, and what we see is that a lot of people with anxiety and depression, they have very high level of cortisol. So, and that cortisol over time, high cortisol secreting from your glands over your body over time increases the risk of you developing a lot of health conditions. And we see one way we help manage, in my research, one of the way we help manage glycemic control is also by decreasing depression and anxiety. So your cortisol level is also associated with your HbA1c level. So hence the reason I bring the mental health piece of it, because I am a clinician. So in thinking about, okay, what are some conditions that increases the likelihood of folks having type 2 diabetes? Depression is a major contributor. Anxiety, yeah. So all of these things really can increase risk for certain groups. And when we see, we see a lot of, there's very, when we get to sexual minorities, you will see various conditions, although there's developing research among these populations, because again, it's developing research. There's not really a lot of research, and even more now, people are being prevented from doing research that really can expand our knowledge in terms of health conditions and mechanisms that underlie these mechanisms, and really could give us an idea of how to intervene. So structural factors. So when we're talking about social determinants and looking at disparities, we have to talk about various levels that really explain why we see disparities, for example, in terms of type 2 diabetes, in terms of obesity between racial groups. So your policies, hiring practices, allocations of certain resources is really important in terms of understanding how these factors, underlying factors that really explain some of the racial differences that you are seeing. For example, redlining is something that my parents explained to me, that when they were growing up, there was redlining in terms of there's certain sections that demarcate where whites lived or black lived. Although my parents grew up, they were born in the late 50s, but still there was not a law like you could, but there is still the redlining. And I think to a certain extent it still exists. And why this matters? Well, that matters into allocation of resources. So even now, they're trying to restructure certain communities because of various voting structure they want to put in place. Well, who's representing you, right? That impact potential resources that might be allocated towards you for that community. So we're seeing, for example, let's take, education. There's some schools that are really, really poor performing, and when we're seeing how much annually, or the budget is, the budget that is allocated to those schools, we in comparison schools in different areas, and at times the distance is really small, but yet the curriculum is night and day. So redlining still exists in terms of not schooling education, and that really, if you don't have allocation toward housing, toward schooling, toward education, that really is going to put certain folks, certain individuals at a very disadvantaged level earlier on. And when we see early earlier discrimination and lack of resources, they do trickle back in terms of what we see outcomes into adulthood. So these things, without any intervention, uh, these things do not just stay in our childhood. They do really predict how folks perform later in life in terms of their income level, associated health outcomes. So these things do not happen in a vacuum. So racism is being, as part of your reading, is being looked at as a determinant of health. It's not, if you see the CDC and also the other previous literature from week one, it's not among racism is not among one of the major social determinants. I think in this literature for this week, it's being proposed as a potential factor that should be looked at as determinants of health, because indeed it is. It is. Racism and racial discrimination is indeed impact various aspects of functioning. So the 2020 Morbidity and Mortality Week report, these reports at times they're done annually and look at various social determinants of health. What are some factors really that undergird what we're seeing in terms of disparity? So lack of healthcare insurance, costs related to care, which you guys, Jen mentioned this, Alexander mentioned this as well. We're seeing these things really trickle down into when we look at this disparities among various racial group, ethnic group, even religious groups. So health-related social needs are really factors that really, it gives you the meat, the background, the context, the information to why you're seeing these disparities, because oftentimes race does not tell the whole story, ethnicity does not tell the whole story, but it gives you, knowing these factors, what are some things that really, if you're dealing with these social determinants, lack of health insurance, so yeah, life satisfaction is likely to be low because you're not healthy. You're not likely mentally, physically healthy because you don't have access to care. And at times you may have access to care. It is poor care. So I was, when I was in grad school, we used to do an internship at a prison. And part of the internship, it's just simple mental health, and it was a men's prison. And it was clear it was psychoeducation in terms of understanding anger. We were not there to provide psychotherapy in terms of depression and anxiety. The reason for that is because for you to do depression and anxiety treatment, you need ample time. You need more structure than we were given. So we were doing just psycho ed in terms of understanding your triggers, anger, which is some of these things were really important to some of the incarcerated folks, because anger was among a really common issue to where, they reoffend for recidivism. But there was a push by not the warden, but some of the folks to provide depression and anxiety because they were seeing it. And we're like, well, this is not what we can provide. Because if we were to do this, to start talking up to people, treating people, well, let's delve into what is underlying your depression. At times it's trauma, but we don't have the time to treat trauma. So you cannot underserve the already underserved. It has to be clear in terms of when you're providing a treatment, when we're providing a program, what you are providing. Here are the parameters, here are the limitations, because you can provide care that actually does the contrast. It hurts people. So, and at times it's just bad, bad care. Like, you have providers who do not care, underpaid, understaffed, So there are a lot of times when even when we see, okay, there is a clinic, there is a hospital, we still see that's near where people, near folks' residents who really have expanded hours that facilitate, accommodate folks' schedules, but nevertheless, we see that engagement is low. And among some of the barriers is that, okay, the provider does not listen, the providers do not care. So and at times the most effective treatment is not given. It's really essential. Oh, this thing is such an annoyance. I was treating patients and I did a referral, and the patient came back and said, well, here's what the doctor said to do. And I said, well, did you ask the doctor, is this the primary treatment for this condition? Well, I didn't. Well, yeah, that's important. You need to do that because unintentionally, at times, providers may see somebody coming, then they assume, okay, well, it's low income. I'm going to give you, you're not likely to afford this, which is understandable. But nevertheless, providing a treatment that's inadequate, you're going to see low engagement. Why should I be continuously engaged in a treatment when I don't see any outcome? So that's really important. So a lack of insurance really you can see why life satisfaction might be a health related social needs that really in lack of insurance is the overall umbrella barrier or factor. Employment stability, utility stability, security, receiving food stamps or SNAP, all of these things, because there's some provision in terms of access you can have with even certain insurance. There's some programs, health programs, some insurance now, used to do various health related programs, and folks will earn points if they engage in them. I'm not quite sure. I know there's been a lot of changes that has happened over the past year or so. So it's important to look at, social determinants of health and how these things may trickle down to health-related social needs, as explained in one of your readings this week. So most social determinants, for in this 2024 report were social isolation and loneliness, lack of social and emotional support, poor health condition, and we know when results were adjusted for race and ethnicity. So the morbidity, let me take a step back. So these type of reports tend to have very large samples. Like I believe it was over 300,000 samples. So these are very national samples typically, and they're seeing these differences across groups. They may look at by state, they may look at within a certain county, but they also adjusted for race and ethnicity. So when you adjust for race and ethnicity, meaning like, okay, you see it at the group level and then you see it at the subgroup level. One example of that, if I'm looking at nurses, satisfaction with Stony Brook among nurses, among nurses, I might also adjust for race and ethnicity. So I looked at overall among nurses at Stony Brook, could be very Stony Brook clinic, but I will adjust for race and ethnicity where I look at the last life satisfaction by race, in comparison to white versus African Americans or white versus Latinos and all of that. So when you adjust for that, what are some differences are you seeing? So when it adjusted for race, there folks receiving SNAP, housing insecurity, we see these things were associated with poor outcome. So differences in lived experience drive health related harms, and there's some biological processes that increases the likelihood of you having a certain conditions. So lived experiences, lived experiences are basically life experiences that are influenced by social or demographic or financial related factors. I believe paper one really, this assignment talks about these various factors that led to the premature death of this doctor. Now I've forgotten his name, and it's a powerful piece in talking about the various experiences throughout that woman's life, his mother, that really serve as, that really projected into her adulthood, meaning that these factors really put her as a disadvantage in terms of choices that she made that continuously impact her as an adult, and subsequently her children to a certain extent. So lived experiences are impacted by social determinants of health, income and poverty, account for a lot of the differences that you're seeing. So it's not just race. It's not it's but as a health disparity researcher, I truly believe, based on the literature, not just my opinion, that if you tackle income, then you will remove a lot of disparities that you're seeing across race, across gender, across rural areas. Not that I'm saying people are not different and we should not respect differences, but I'm saying in terms of looking at disparities, if we tackle that, we will see a significant improvement in health outcome. And it's not just Marie saying it, it's the literature, because a lot of these things that we're seeing, income, poverty, explain a lot of the variability. Meaning that if I put, this is quite annoying. My apologies. As you can see, my hands are right here. I am not touching this. Um, so if you are seeing, just make biomarkers, yes. If you, I'm a researcher, so when I do research, I look at various factors that explain how different factors explain an outcome. So I'll take for example, physical type 2 diabetes, poor glycemic control. So having it HA1C, for example, we had a research intervention research where we were including people with HA1C 8 or greater, 8 or greater, and this indicator as poor glycemic control. So we had to have a lot of factors that really explain the relationship, the nature of the relationship to why we see poor glycemic control. So we of course we had diet, we had physical activity, we had stress, and we looked at these things and seeing, okay, which one of these things, of these factors, is really explaining the poor glycemic control. So when we're saying that a factor like income and poverty account for a lot of disparities, we're saying that the level of the relationship that we're seeing, and I'm not going to go very technical, I'm not going to put you to sleep by statistics, okay? Because I know it's late. But when you look at the level of the association between certain factors and you put it in a model, we see, okay, well, this factor is associated with this, but there's a stronger relationship among these factors. For example, we see diet account for a lot of the poor glycemic control we were seeing. Physical activity as well, but diet had a stronger relationship. So similarly, income and poverty really account for the various social determinants of health we're seeing that are associated with poor outcome among race, ethnicity, and so let me just move a little bit faster to this. Of course, biomarkers influenced by income and poverty provide essential ways to understand the literature. When you're saying, oh, race differences, I want you to think about what are some biomarkers that may influence this. So Geronimus, pretty cool name, Geronimus. Okay, anyway, look at the effect of lived experiences, allostatic load. And you had this as part of your reading across different subgroups, race and ethnicity and poverty levels. They looked at 3 different groups in Detroit and compare these groups with the national samples. So Black, whites, Mexican, I believe, in Detroit, poor area of Detroit, but they also compare it to the national samples in terms of looking at these allostatic load. So allostatic load is just, it's a composite measure, meaning that it has several indicators, including BMI, inflammatory and cardiovascular, metabolic, diastolic, systolic, blood pressure and all that. So, and they basically, contend that, there's going to be a place effect on allostatic load. And they also think that there is members of all 3 racial group will have higher AL relative to the national samples, national averages for these samples. And they talk about an interaction effect among race and ethnicity and poverty. So interaction effects, again, if you may not have used statistics or you have used it, you forgot about it because you didn't, it's a language. If you're not using it, you forget about it. So interaction effect is basically the relationship between variables vary by a third. So an interaction between race and ethnicity for poverty is just saying that allostatic load, the level at allostatic load, you will see the outcome varies at a different level of race and ethnicity. So let's say if you were poor, if you're African American and Latino, or if you're African American, that varies. That will be different for you. So moderate African American and Latino, so race and ethnicity moderation. Or if you're having an interaction between poverty and race, which one of the results the models focused on, it's basically if you're African American and you're poor versus if you're African American, you're not poor. So the outcome varies at different levels of a second variable. So you've seen this as part of your reading. So briefly, what we see overall is that, and this is the results are in bold for table 1, which is taken right out of the Geronimus, is to show that you have a national sample, or just in looking at annual income. This is the national sample on the left, and these are the Detroit subgroups. And you can see significantly, even though, we're just looking at percentages, and they're in inferential statistics like p-values to determine whether this is significantly different than this, we have eyes. 6% versus 38% is significantly different. You don't need a statistical test to really see the disparity that you have national sample and you have a subgroup within 38%. This is this is 6%. And similarly, if you see poverty rates between individuals ages 25 to 64, comparing the national sample to the subgroup in Detroit, we see that is significantly different, markedly different percentage with the choice subsamples for whites, Black, and Mexican showing really higher poverty level. So when we look at poverty to income level, so that's Geronimus explaining this, determining whether people were poor poverty to income level, which is PIR. We see that the Black subgroup had higher level. So this is the PIR1 greater than 1, PIR less than 1, and PIR less than 1 is indicating at the poverty level. And again, is looking at these differences that for whites, PIR less than 1 among Blacks, PIR less than 1. And so we see, with African Americans had a significantly higher, were in the poverty level based on this marker. So when we look at this across for the allostatic load across race, and then comparing it to the national sample, we're seeing those differences, really significant differences in allostatic load. Because allostatic load, as your, the article, the readings demonstrate, all of these things really is basically wear and tear on the body that increases the likelihood of you being able to fight a certain condition, how your body is functioning, whether it's at optimal level. So in all of these things are proxy measures for premature mortality if they're going in, of course, in the bad direction. So we see that, well, typically we'll see, okay, well, there should be substantial difference in terms of the white sample, in terms of Black and white, but when we're seeing by the national sample, we're seeing there's a significant difference, which means there's a concentrated poverty in that area that really is a public health, it's a public health issue that, and anything about that area of Detroit is that it's a concentrated poverty level that we're seeing that are impacting folks. But nevertheless, when the study is comparing across race and ethnicity and allostatic load, is providing an interesting outcome. Any questions as I'm going through this? Have I bored you to death with the statistics? Okay, these are and I picked and choose what we looked at. It's really to give you an idea that, well, when we compare, it's not just quite clear, like, okay, well, disparities is for African Americans but there white folks, certain white subgroups are impacted. Folks, other demographics are impacted, and we're seeing what is explaining these differences is poverty. It is not just race; it is poverty. So explaining, to others, okay, why this is important, why you need to kind of like go down the layer and see, okay, what are some things that are maintaining health disparities among certain groups, or even within certain groups among whites? What are some things that are maintaining poverty? What we see is, okay, geography, income. So geography at times goes in hand with income. So it's really important because it tells you a better story, a more coherent story than say, okay, just race differences. So, okay, well, if you are a student and you being taught, oh, you know what, there's racial disparities. You're like, well, okay, there's racial disparities. But if you are being taught, okay, here are the factors that interact, that contribute, that support, that maintain that, okay, here are these factors. Okay, how do we intervene? How can we intervene? So understanding the literature and what are some factors that underline disparities is really important to really help us to think what are some ways in which we can intervene or even prevent certain disparities, certain determinants of health. How do we, look at various factors that really put people at a lower, prospect in comparison to their high income counterparts. Similarly, when we look at means allostatic loads for the sample, comparing the national sample with the Detroit sample across the subgroup, we're seeing, interestingly, there is not a difference. So there's not a statistical difference between mean allostatic load score between the Detroit sample and the national sample, but rather we're seeing the difference stays among whites and among the Mexican subgroup. And how we do understand that is because of the p-value. The p-value is a statistical measure that tells you that test mean differences among group, and it tells you that 0.05 is anything below 0.05, higher than 0.05 is not statistical difference, meaning what you're seeing between groups is not really significantly different. If you are higher, you have it's higher than 0.05. and again, I'm not going to statistics, but if you want to know more, you can let me know. But for the purpose of understanding this, when you're looking at p-values, it's testing a mean difference between two groups, because I want you to know that. And of course, because it really helps you to understand the literature and there are various videos that really, quick videos that really goes into p-values. And statistics at times can be a little bit daunting because you have, if you have not used it, but once you use it, it's like I said, it's a language. If you speak it frequently, you're more likely to retain it. It's really not that complicated. Well, some of it's complicated, but but p-value is pretty straightforward. All right, so in this table, what I wanted to look at, because we talked about part of their hypotheses is like there's going to be an interaction between race and poverty. So this is the coefficient of coefficient value, and it's showing that in comparison to, so the white is the reference group, so black is being compared to a reference group. So in any model, for example, let's say you are doing a regression model, you're comparing groups, you have to have a reference group. So just for your understanding, and it's showing that there is a race effect here. And then we're seeing, okay, when we go further down, there is an interaction. So if you're white or poor, if you're black or poor. So this is what I was telling you about. Okay, interaction effect is basically the relationship between allostatic load score is, for black varies if you're poor, if you're not poor. If you're white, poor, or black poor. So when it comes to Mexican and poor, we see there's no statistical differences here. All right, so recap. Basically, we know health disparities, among racial and ethnic group. It's really well documented, and we often hear that in the media. And substantial inequities explain a lot of the outcomes and disparities we are seeing. So race or ethnicity alone, those differences does not really do not tell the whole story. Structural racism and discrimination substantially contribute to what we are seeing. Some of the disparities we are seeing. Allostatic load is really one way. Public health is really seeing what are some various markers that goes into this composite measure when we looked at BMI, we look at blood pressure, how do we see the wear and tear in the body, and how is it these scores, how are they different across different groups? And we see there's a place effect, right? Because if you look at Detroit in comparison to the national sample, we're seeing the very high concentrated poverty and associated allostatic load in comparison to the national sample, because you should be seeing lower, because it's a national sample, national average. Detroit alone has higher allostatic load being scored than the national average. And we see a race poverty interaction effect on allostatic loads. So any questions? So the goal, as I mentioned, the goal of this lecture is to make sure that, as we talk about race ethnicity differences, when we're talking about poor outcome for certain groups, that it's not spoken in a way that pathologizes or, pathologize the group or discriminate or has these stigmatize the group as, okay, this is intrinsic to being Muslim, intrinsic to being Latino, intrinsic to being African American, extrinsic to being white, living in a poor area, but more so these demographics represent our umbrella factors that are really being girded by so many interacting factors, some of which are just poverty and income, which really interact, they have a reciprocal relationship. If you are low income, you'll more likely to, make a certain, you're more likely to be poor. If you make less than 10,000 a year, which some groups, happen to still make, you are gonna this is high level of poverty. So when we see poverty, and we gonna see in previous readings, and well, week one readings, we're seeing, well, education goes into it. Well, also goes into education. If you have poor performing school, we see, okay, high dropout rates. If you're not graduating, your prospect in terms of income is fairly low. So we have a very cascading effects of certain social determinants that really trickle down to explain the disparities that we're seeing among various demographic groups, that really give you really a more in-depth understanding of why these disparities exist, and potentially what are some things to really see as we talk about, we work in various of services. How do we think about these factors and how they impact our patients? All right. These are some references if your heart desires or you want more ratings in addition to what you have. All right, I will see you in the next module. If you have any questions, I will stick around for a minute. If not, I bid you goodbye and good night.
Thanks so much. Have a good night.
You too.
Have a
Have
good
a
one.
good night. Bye-bye.
I got a question.
Sure.
It's just about the paper. Do you want us to primarily stick with the articles you gave us, or are we allowed to like grab articles, like outside articles?
In addition to,
Yeah.
yes. Well, absolutely. The
Okay,
more the
because
merrier.
because I wanted to talk about like one of the main differences, because it was
Mhm.
2008.
Mhm.
Affordable healthcare wasn't a thing yet. So
Yeah.
I
Yes.
caught that. Yeah.
Oh, absolutely. Yes. You are welcome to use additional resources. Yes.
Okay. All right. Thank you.
You're welcome. Looking forward to reading your work, guys.
Thank you. Have
All
a
right.
good one.
You too. Bye-bye.